All right, wonderful. Good afternoon, everyone. Happy Friday.
Good afternoon, everybody. So good to see you all. Beautiful day here right outside of Philadelphia. And my name is Sue Weldon. I'm the CEO and founder of Unite for Her. Welcome to our Ask the Experts. And I'm here with my colleague. Go ahead, take it away.
Yeah, Erin Pellegrin, our Senior Director of Culinary Nutrition and Education. And we are both so excited to be here for our Ask the Experts on a topic that is so prevalent and comes up all the time in our community. I am so glad we're diving into some of these questions.
I am too. I am too. And before we get started, I have to thank our sponsors. Our virtual education events, we call it Unite for Her Connect now. You might see that new logo. We really do have this whole station. I always say it's our own little Unite for Her television station, but they're presented by some lead sponsors and we can't do it without them. So a big shout out to West, Merck, Lilly, and Gilead Sciences, with additional support from our gold sponsors, Pfizer, GSK, and Daiichi Sankyo, and our supporting sponsors, AbbVie, Agendia, and TerraSera Therapeutics. Thank you all for your support. Thank you for leaning in. This is how we get our experts to come on, and we develop this incredible criteria, and we can't do it without you.
Absolutely. And we don't just stop here. So we've got so many more education events coming to you. So I always like to kick off our segments with a little teaser of what's to come. And we've got a lot happening in the month of May. It's hard to believe we're already at the end of April, but a lot to look forward to. So if you've attended any of our education segments in the past, we have done pain management, focusing on the different integrative therapies that we focus on at Unite for Her. And we are wrapping up this series focusing on pain management with yoga. So this will take place, this is our speaker series. This will take place on May 8th at 6:30 p.m. Eastern Time. And one of our yoga providers, Diane Kistler, will be with us. She is an expert in this space, super knowledgeable, and she'll not only be sharing with us the science behind utilizing yoga as part of your pain management regimen, but also teaching us what the science says about its effectiveness and how we can all build this into our overall healthy routine. She'll also touch on the pain and stiffness and side effects that our community often shares with us when they start these endocrine therapy or hormone therapy medications. Yoga is even effective for that. So if that is speaking to you, be sure to join us for our speaker series. Again, that will be May 8th at 6:30 p.m. Eastern Time. It will be recorded, so if you can't make it, do not worry. All of our education segments are recorded and on our education network, UFH Connect. So if you go to uniteforher.org/UFH Connect, you will see not only that recording and today's recording, but our entire history video library. So definitely check that out.
Yeah, and if there's a topic that you're interested in, we have a wonderful search bar. You just put that topic in, and then all of the events that we've done over the past 5 years, Erin, go to 5 years,
Yes. Yeah.
pop up, and we keep an inventory of them. We make sure they're up to date. Everything is still relevant. So know that you have the best, most factual information on that library. Yeah.
Absolutely. Yeah. And utilize that search tool. I use it every day as I share
Oh, I love it.
videos to our community.
Yeah, for sure. So just a little bit about the format. I think Erin touched on it as well, but we do have our dear Rachel watching the Facebook Live. So she is going to be sending us any questions that come in. So just know that you can do that live in real time. We already have quite a bit that came in on this topic, Erin. So just know that we want to be interactive with you. And if we don't get to any of the questions, Dr. Taiwo is right there ready to answer them via email, and we will pop them on that library as a Q&A section in case we miss any that came through. So know that that is available, and we look forward to kicking it off.
Absolutely. Yeah, let's bring on our speaker.
All right. Hi there, Dr. Taiwo.
Hi, ladies. Thanks for having me.
Oh, thank you for joining. You are the best. And I'm going to start with a little bio on Dr. Taiwo. She is the Assistant Professor of Medicine at Weill Cornell Medicine, an attending physician and Hematology Oncology Fellowship Program Director at New York Presbyterian Brooklyn Methodist Hospital. She received her BS in biology at the University of North Texas and her MD at Temple University School of Medicine in Philadelphia. Following her residency at Boston University Medical Center, Dr. Taiwo completed a 3-year fellowship in hematology and oncology at the University of Texas Southwestern Medical Center in Dallas, Texas. In addition to our clinical care, Dr. Taiwo's work addresses disparities in breast and healthcare with a focus on improving clinical trial enrollment, community engagement, and patient advocacy in breast cancer. As a researcher, she has contributed to several studies on cancer presentation in urban and minority patient populations, and we are also honored to have her as an expert, as a member of our Women of Color Task Force at Unite for Her. So, Dr. Taiwo, thank you. You always make time for us. We appreciate you. And this is a topic that has a lot of interest from our community, and always good to answer their questions. So thank you for joining.
Absolutely, absolutely. Very happy to be here. I love the Unite for Her community. I'm always honored when I'm asked to be present in whatever you all do. So yes, lots of important questions I'm sure will be asked, and rightfully so. Endocrine therapy is used in majority of the breast cancers that are diagnosed in the US. So I reckon there are lots of questions from patients who are in the treatment. So yes. Let's do it.
Thank you. All right,
Yeah.
let's dive in. Erin, I'm going to let you start.
Absolutely. I love this. So I think a good place to start is the basics, right? When we talk about endocrine or hormone therapy, what is the difference between tamoxifen and taking an aromatase inhibitor? So can you clear that up for us?
Yes. So when we're talking about endocrine therapy in general, we're trying to find medications to either reduce estrogen production or estrogen activity in the body as a way of reducing breast cancer recurrence, reducing the activity of breast cancer in patients that have estrogen receptor positive breast cancer. Like I mentioned, that's about 70% of the breast cancers that are diagnosed in the US. So unlike tamoxifen, which acts as a estrogen blocker, tamoxifen is a drug called it's a selective estrogen receptor modulator, which means it acts like estrogen, even though it's not estrogen, and binds to the receptors that estrogen tends to bind to that can stimulate progression and proliferation of breast cancer. By having tamoxifen bind to those receptors, it makes it difficult for estrogen to do what it wants to do to stimulate breast cancer. So it's acting as a molecule that's competing with your estrogen. So it doesn't change the estrogen level in your body. It's just competing for the receptors. An aromatase inhibitor, and we generally use tamoxifen in premenopausal patients, but we use it in postmenopausal patients too in the appropriate setting. An aromatase inhibitor is different in that it actually affects the amount of estrogen that's being made in the body. Aromatase is an enzyme, if you may, that's made in fat cells, and its job is to convert hormones to estrogen. So by blocking aromatase, you're preventing these hormones from being converted to estrogen and reducing the risk of estrogen then binding and doing what estrogen wants to do in an estrogen sensitive breast cancer. So an aromatase inhibitor does reduce the amount of estrogen that's being made in the body. So that's the main difference. And obviously premenopausal patients are still making estrogen because their ovaries are still functional. So we're given a drug that's competing with the estrogen that's being made. Postmenopausal patients generally are no longer making estrogen from the ovaries, but they have other ways of making estrogen through fat cells, through the adrenal glands. So you're giving them a medication to block that conversion to estrogen. So that's the main difference.
Love that. And we got a question already coming in from Facebook. Can you explain the difference between neratinib and how this compares to letrozole?
So neratinib is not an anti-estrogen medication. So letrozole is an aromatase inhibitor. We have 3 oral aromatase inhibitors. We have letrozole, we have anastrozole, and we have exemestane. Those are the 3 aromatase inhibitors. Neratinib is a targeted agent. It's an oral molecule that's primarily used in patients who have a HER2 positive breast cancer. We generally use it in patients who have a high-risk HER2 positive breast cancer, particularly those that are also ER positive, because some of the data shows it's more active in patients that are HER2 positive, but also ER positive at the same time. So they're completely different drugs, and they're targeting completely different molecules, right? Aromatase inhibitor is reducing estrogen production. Neratinib is a drug that's targeting HER2 in breast cancer.
Perfect. Thank you.
You know, we hear so much about the side effects. Obviously, Dr. Taiwo, that's the field that we're in, where we're helping our community manage their side effects and symptoms. Which has worse side effects in your opinion? And can you lean into some of those?
Yeah, absolutely. So I don't know that I would say which has worse side effects. The side effects are different because the mechanism of action is different. For patients who are on an aromatase inhibitor, the side effects are primarily side effects that are associated with being postmenopausal. We're reducing estrogen levels, right? Estrogen, even though it does stimulate and promotes progression or can promote progression of breast cancer, if it's a hormone receptor positive breast cancer, estrogen has a lot of positive things that it does in the body in women and men, but obviously we're talking primarily about women here. Estrogen is important for your bone strength. So when you're in an aromatase inhibitor, the decline in the bone density, the risk of osteopenia, the risk of osteoporosis goes up. Estrogen is important for joint lubrication. So when patients are on aromatase inhibitor, they will complain sometimes of joint stiffness, call it arthralgia. So joint stiffness, bone pain, muscle aches, that's because estrogen is involved in supporting the health and activity of the bones. Estrogen is important for your skin texture, your hair texture. So patients will complain of dryness of their skin, dryness of their hair, dryness of the vaginal mucosa. Estrogen helps in lubricating the vagina as well. So those are the side effects that are associated with an aromatase inhibitor. Obviously, the levels of estrogen drop as we get older. So some of the side effects that we see also related to being postmenopausal, metabolic syndrome, weight gain, those are things that we see increase in incidence as we age, regardless of whether you're on an aromatase inhibitor or not. But being on the aromatase inhibitor increases the risk of that happening, right? As it pertains to tamoxifen, some of the symptoms associated with being on an AI are also associated with tamoxifen. The hot flashes, the vaginal dryness. We generally don't see bone pain or joint aches associated with being on tamoxifen. Once again, because they're completely different mechanisms, we're not reducing the body's estrogen levels. We're just blocking receptors. But there are other side effects that we see in tamoxifen that we don't see in a aromatase inhibitor. So there's a risk of blood clots, particularly in patients who maybe smoke or do have a personal or family history of blood clots. There's a risk of uterine cancer. It's very low, but it's present. But this is primarily in postmenopausal women. We don't see that risk in premenopausal patients, thankfully, because we do use tamoxifen mostly in premenopausal patients. The risk of endometrial cancer is not documented in premenopausal patients on the medication. There's some data showing increased risk of cataracts in patients on tamoxifen. So which one's better? It really depends on what your underlying comorbidities are. If you're someone who has a family history or personal history of blood clots, tamoxifen may be worse for you. If you're someone who has rheumatoid arthritis at baseline, being in a aromatase inhibitor may be more difficult than being on tamoxifen. So it really depends.
Yeah, Dr. Taiwo, I feel like I've always associated tamoxifen for our premenopausal women and AIs for our postmenopausal. But am I hearing that sometimes postmenopausal women take tamoxifen or no?
Yes, sometimes they do. When we first started using anti-estrogen therapy in treatment of breast cancer, all the initial studies, now decades ago, were really all with tamoxifen, whether it was for prevention and for treatment. And then more studies started coming out with the aromatase inhibitors, showing that aromatase inhibitors are slightly more effective than tamoxifen in postmenopausal women. So that shift was made. But tamoxifen is still effective. So if we have patients who, for whatever reason, there are underlying medical issues, they have terrible osteoporosis, osteopenia, they have rheumatoid arthritis or underlying autoimmune disorders and can't tolerate being on a aromatase inhibitor, tamoxifen definitely will be recommended, So, but it's not first line, but we do use it as an option. Or if you can't tolerate an aromatase inhibitor, the hot flashes are really bothersome, the arthralgia, the myalgia, then we use that as an alternative. Absolutely.
Okay. You also talked a little bit about like the effects on bones, and I didn't hear really that high effect when you're on tamoxifen on your bone density. Is that true? Is there any type of bone density issues connected with tamoxifen?
Generally not, right? And the reason why is, once again, tamoxifen does not reduce your estrogen levels. That really is the main issue. As we're giving you medications to decrease estrogen production, all this other side effects occur or can occur. Tamoxifen doesn't change your estrogen levels. So the estrogen that signals to the bones to rebuild itself, to strengthen itself, that estrogen is still being made. Actually, what we found is there are different receptors. You know, you have receptors on the breast cancer cells, you have receptors on bones, you have estrogen receptors in different parts of the body. Tamoxifen actually binding to the estrogen receptors on the bones appear to actually stimulate and improve bone density. And because it's
Wow.
acting like tamoxifen, even though it's
Wow.
not, it's binding to those same receptors. And that's why we don't see the same effect on the bones as we do with an aromatase inhibitor, which is shutting down your estrogen production, or at least reducing your estrogen production.
Wow. And then one more, just and then I'll let you jump in, Erin. So will your periods stop on tamoxifen?
So the It really depends. Everyone's different. A body's response to tamoxifen really depends on your body. Tamoxifen doesn't stop you from ovulating. It doesn't stop you from being premenopausal. But how your body responds to those changes, some patients do notice that their periods are lighter. Their periods may be stop, or their periods may be a bit odd, and then finally kind of find its new baseline. And then some people don't notice any difference at all while they're on tamoxifen. So for our patients, primarily the premenopausal patients, they're on tamoxifen because they are premenopausal, so they're still fertile. Part of the conversation is we do not recommend you get pregnant while you're on tamoxifen because you can get pregnant. It's not shutting down your ovarian function. So even if you're not having periods or your periods are a bit off, they've done studies looking at the estrogen levels of patients on tamoxifen who have irregular periods, or their periods are a bit, have maybe stopped for a bit. And the estrogen levels are actually the same in this patients. So your fertility still remains, even if the periods is a bit off. So it really depends on how your body responds to this hormonal changes.
And
Wow.
sorry, Erin, one more question. Like, one
No,
more question.
please.
So,
Yeah.
so when you're talking about fertility then, and you say you don't recommend getting pregnant while on tamoxifen, and you know that sometimes it's 5, 10 years that they're on tamoxifen. So is that pretty much shutting down, hey, as far as having any more children, this is the time frame. We recommend that you do not, or have you ever had any women get pregnant while on tamoxifen, and what happens?
I've had patients get pregnant on tamoxifen, and it's a very anxiety provoking period because tamoxifen is a class G drug. It is known in animal models, not in humans. It could actually cause birth defects in the fetus, which is why we recommend birth control, some form of birth control, whether it's a physical barrier, whether it's a IUD, non-hormonal, obviously. But thankfully, the two patients of mine who've gotten pregnant while on tamoxifen have ended up having normal and healthy babies. But in terms of patients who are in endocrine therapy, whether it's tamoxifen or we're giving ovarian suppression with an aromatase inhibitor in the younger patients, who do want to get pregnant, having a diagnosis of breast cancer, being treated for breast cancer is not a contraindication to pregnancy. It's a conversation that needs to happen with the medical oncologist. There was a study that was actually published a couple years ago. It's called the Positive Study, where these were young patients, premenopausal patients who needed to be on endocrine therapy post-surgery chemotherapy and whatnot. They had been on therapy for about 2 to 3 years. It was held for a few months. They got pregnant, and then postpartum, they were resumed on endocrine therapy. And the incidence of breast cancer, mortality or recurrence was actually not significantly increased in those patients who stopped endocrine therapy. So it's a conversation to be had. Obviously, it's what's your risk? What are the concerns? Some patients are very high risk of recurrence that even a few months off of therapy is concerning enough to recommend not getting pregnant. But these are conversations to be had. Nothing is an absolute contraindication. It's all about the risks and what risks are you willing to take. And as long as you have all the information, then, you make the best decision for you and the consequences that come with that.
I'm so
I,
happy to hear you talk about all this because 21 years ago, I don't remember those options.
Yeah,
Dr.
we didn't have
Taiwo.
the studies.
So
I
I just remember, like, if I took tamoxifen, I was done. I would not have any more children. You are not going to move forward in any type of fertility, or periods would stop. A lot of things were affected there. And to hear you say all this gives so many young women hope. It just makes me smile. Yeah.
Absolutely. Part of the conversation in our young patients who have a high risk enough cancer and they need to get chemotherapy or whatnot, if having children is important to you, you haven't had them, you plan on them, part of the counseling before we start treatment is referral to fertility specialist for those who need to harvest and freeze their eggs, or those who want to do that with their partner for embryos. It's all part of the pre-treatment. You're getting your echo, you're getting your port, okay, you're getting, fertility consultation, and okay, when are you starting chemo? Let's get your eggs harvested, let's get them frozen, and then we initiate treatment. Yes. So a lot of progress being made, and I'm grateful for all those young women. I'm sure they are too. But it's nice to have those options and to be able to have a conversation saying this diagnosis is not the end. There's still the whole point of what we're doing is so you can have a life after all of this is over.
Amen.
amazing. Yeah. Absolutely. And I'm glad you called that out. We did get a question in from viewers on Facebook about that recommended time. This particular patient is on Lupron and letrozole, but wants to have more kids. And so I think what I'm hearing in terms of, is there a recommended time to pause it? That's really an individualized conversation with that patient and their physician. And what are those risks and what does that time period look like? Am I hearing that correctly?
Yes, I mean, that's pretty much what I'm saying. I mean, in terms of the study, patients who were then allowed, well, not allowed, but patient who then decided they wanted to have children, the recommendations were they had to have been on treatment for about 2 to 3 years before those attempts were being made. And then in terms of when you can actively start trying to get pregnant after being off of Lupron, your AI or tamoxifen, it's usually about 3 months or so that we say to kind of get it out of your system, 3 to 6 months, and then you can actively start trying. Many patients who are getting Lupron are getting a Lupron depot. So these are long acting. It takes a while for it to get out of your system. So generally about 3 to 6 months, yes.
Wonderful. Thank you for that. So also talking about timing, we talked a little bit about tamoxifan's relationship with bone health. You've also talked about aromatase inhibitors and how they can, because of how they, reduce the production of estrogen. In terms of bone modifying agents, or when that discussion needs to be had, if and when would someone want to start looking at the various agents that are available to them, and if that needs to be part of their long-term picture?
Yeah, that's a great question. And it depends on what agent you're on for anti-estrogen therapy. We talked about tamoxifen not necessarily causing low bone density in premenopausal patients. So for a patient who's on an AI, generally getting a bone density is part of our pre-treatment initiation assessment. For patients who have low bone density to begin with, or osteopenia, or even osteoporosis, obviously, we will start them on a bone modifying agent as a way of improving their bone density and preventing worsening of the bone density. For patients who already have osteoporosis, I wouldn't say putting them on an AI is an absolute contraindication, but we're very aggressive about making sure those patients are getting their bisphosphonate or whatever agent is being used to treat the low bone density. So that we use as prevention, prophylaxis, or treatment. But we also have data for patients who are considered high risk enough, whether it's young patients who've gotten chemotherapy for their breast cancer but do not have osteopenia or osteoporosis. We have data for the bisphosphonate in this particular instance is zoledronate hyaluronic acid used every 6 months. We do it for 3 years. So obviously it's protecting the bones, even though you're premenopausal. The fact that you got chemotherapy increases the risk of osteoporosis and osteopenia anyways. But some of the data also shows reduction in the risk of disease recurrence. Why and how is that related? I don't think there's any good answer as to what that pathophysiology is. But so we also use bisphosphonates as risk reduction, particularly in patients who are young and high risk enough to warrant chemotherapy. And yeah, so we monitor the bone density every 2 years, the current guidelines. And if there's improvement, there are conversations about, okay, these are things you can continue to do. Maybe we hold off and continue to monitor. So it's on a case by case basis.
Okay. Wonderful. That's
I
really
know.
good to know.
Yeah, we look at managing some of our side effects with some of these AIs and tamoxifen, and some of the questions were, how do I manage the hot flushes and how do I manage the joint and the muscle aches? And truly, Dr. Taiwo, this is where Unite for Her comes in with a lot of our integrative therapies like acupuncture, which saved me from my hot flashes, 21 a day down to 9, Dr. Taiwo, when I did acupuncture. But can you add to that? We know that, a lot of our integrative therapies, whether it is movement and supporting bone strength and acupuncture and all that science and research is there. Hence why we are so successful in this space with our medical community. Do you have anything else to add to managing those hot flashes and joint and muscle aches?
Yeah, as it pertains to hot flashes, it's the same thing you recommend to patients who are having hot flashes from being in a menopausal state and not necessarily on an AI. There's some very simple things that may help. Obviously, when a patient is on an aromatase inhibitor, sometimes it seems like the symptoms are actually more intense than just the regular, menopausal hot flashes. But there's certain foods and certain things that we know can kind of aggravate it. Things like coffee. So if you're a coffee drinker, you may need to drink less coffee. Spicy foods. These are things that cause vasodilation when you're having the hot flashes. It's because the blood vessels are dilated, they're more open, so there's blood flow. So things that can cause your blood vessels to open up more, coffee, spicy foods can aggravate it. So limiting some of those. But as it pertains to arthralgia, there's data for exercise and weight loss helping, massage also helping with that. You mentioned acupuncture as well. So, just some of this, and then, pain medications as needed, your Tylenol, your ibuprofen, those are sometimes helpful. For patients who are on tamoxifen, we have some data for using low dose SSRIs. These are low dose antidepressants like venlafaxine. We do have data for that in lower doses than one would use for depression or anxiety. There's data for that. Most patients are already on many medications, sometimes do not want additional medicines, but we do use that sometimes if you've tried everything. And so, it really depends on what your body is responding to, but those are all the interventions that we do have, arthralgias, myalgias, your Tylenol. But physical activity, it sounds counterintuitive, but we have very good data. When everything hurts, go out there and exercise. It actually helps. It's just getting motivated when you don't feel good. It's really difficult. So it's just looking for ways to encourage our patients to consider that. Yeah.
We just feel like just walk forward,
Yeah.
moving,
Yeah.
keep walking.
Yeah.
It's positive
Yeah.
that way.
Yeah.
I've been hearing so much, and another question that came up just about HRTs and hormone replacement therapy. And, 20 years ago, when we heard that, it was just definitely like absolutely not for breast cancer. And the studies were different then. It was only for that one hormone, if I'm correct, is estrogen. But now I heard that the studies are really showing two hormones together in this HRT that is helpful. Could you relate, like, is that something people could actually consider, some of our cancer communities, or no?
Yeah, so generally not in breast cancer patients, right? So some of the old studies, which were the Women's Health Initiative studies that were looking at the effect of hormone replacement therapy on women, right? Because we know that as you age and your estrogen levels go down, there are all this cardiac adverse events that develop. We've talked about the metabolic syndrome. So replacing the hormones was one way of trying to get your estrogen back to, I guess, premenopausal state to help mitigate some of the side effects, or not side effects, some of the health outcomes that are associated with being postmenopausal. But what they found in those studies was that there was an increase of breast cancer in certain patients. But what we now know is it's like an exaggerated sort of risk.
I
Hormone
heard.
replacement
Yeah.
is not contraindicated in most patients, right? Right now, the guidelines are yes. So estrogen being used with progesterone is what the recommendations are in terms of hormone replacement therapy. That being said, for patients who want to be on hormone replacement therapy, it's also a conversation with your physician. But generally, if you're considered high risk for breast cancer, whether it's based on your family history, whether it's based on your genetics, and a whole bunch of other factors that are put together to figure out what your risk is, we may not recommend hormone replacement therapy if you're at high risk for breast cancer. And we definitely don't recommend hormone replacement therapy in patients who've already been diagnosed with breast cancer. But if your risk is low, then, it's likely okay to be on hormone replacement therapy. If your risk is questionable, it needs to be a conversation with your physician. If you've been diagnosed with breast cancer, we do not recommend hormone replacement therapy. Now, for women who do have symptoms of vaginal dryness that's associated with being on tamoxifen or an aromatase inhibitor, they've tried the vaginal, moisturizers and lubrication and nothing's helping. Topical vaginal estrogen is fine in those patients. We've done studies, multiple studies, meta-analysis showing that topical vaginal estrogen does not increase the risk of breast cancer in patients who've already been diagnosed with breast cancer. The amount of estrogen getting into the bloodstream from that topical vaginal estrogen is minimal. So that's the one area where anything estrogen is probably okay. But in terms of a hormone replacement patch or pill, we definitely do not recommend that in patients with breast cancer.
Thank you for clarifying that. Do you have a product that you would recommend for the topical vaginal estrogen? Is there one that like you can just get this over the counter? Is this a
No,
prescription?
it's a prescription. It's prescription. So yeah, you would have to see your doctor and they would have to
Okay,
prescribe it.
great.
And I get a lot of questions from the gynecologist who the patient's gone to see their
Yeah.
gynecologist and they're having all the symptoms. The gynecologist wants confirmation that it's okay from the oncologist to prescribe it. And we say, yes, please prescribe it.
Oh, so good. Okay, so that's another confirmation as well. Thank you. There was quite a bit you cleared up for me there, and I appreciate that. Yeah.
Wonderful. Good. I want to go to one of the questions that came in live on Facebook as well regarding aromatase inhibitors. And it sounds like there may be a recent study that came out on perhaps cycling of an aromatase inhibitor. So this person said there's a study of being on AI for 9 months and off for 3 months that show very little difference in recurrence. Is this something that you've read or are aware of? And can you comment on that?
So I'm aware of the study. It's not standard of care. There are always studies that are ongoing with a small number of patients. And if it's the endpoint is met, then the studies become larger, right? There's so many people who are on an aromatase inhibitor. So a small study that's showing a possibility of changing our current schedule is unlikely enough to change our current standard of care. But then as there's more and more data and we have more patients in the pool of studies, that could be something that's considered, but I can't comment too much on it because I don't know much about the study. And it's definitely not a large study where there's enough information and enough conclusion to change our current standard of care.
Great. Okay. Thank you for clarifying that. I want to just continue a little bit, going back to aromatase inhibitors and some of those long-term side effects. You've talked about bone health, but one of our questions that came in prior to this segment from our community was about coordinating with all of the physicians about letrozole, aromatase inhibitors, and other long-term health issues that may arise, high cholesterol, affecting overall heart health. Do those high risks for developing bone disease, heart disease continue? Is that risk still present after the drug is stopped? And what factors do doctors look at when deciding if a patient should be on an aromatase inhibitor for 5 or 10 years?
Well, that's a great question. So in terms of the side effects and how long they last for, or if they're reversible, there's certain side effects that resolve very quickly after being on this medications. So the hot flashes or the change in libido that some women do experience while they're on an AI often results within weeks of being off of the medication. Things like osteoporosis. Once osteoporosis develops, that's not reversible, which is why the goal is to prevent osteoporosis. But some of the side effects are things that we do see as women age and go through menopause. So some of it is that the medication probably puts you in that space a lot faster than you normally would be. So they're not generally reversible. So the goal really is to try to involve yourself in risk modifying,
Yeah.
behaviors, whether it's if you're overweight, weight loss, if you have a family history or personal history of high cholesterol, diet, exercise, all the
Yeah.
important things to prevent, that developing. But once you've developed hypercholesterolemia, that generally is something that requires you to be treated long term if it's one that requires medication, but it's the same behavior whether you're on the medication or not. It's like once you develop high blood pressure, you develop cholesterol, even if you're not on an AI, it ends up being this chronic medical issue that
Yeah.
needs to be managed long term. And it's the same in patients who are on an AI. And then the second part of the question about how do you determine who gets to be on 5 years or 10 years? A lot of it depends on the patient's risk, right? So generally, if a patient has high stage disease, high risk disease, they've got positive lymph nodes, you may want to put that patient on treatment for 10 years over 5 years. Some of the data is showing longer therapy is more effective than shorter therapy. We do have now genomic testing that can help you figure out who should be on, who benefits from, extended endocrine therapy and who doesn't. There's the, breast cancer index. There's the mammoprint, which are genomic testing to get a sense of who may benefit from chemotherapy or not. But part of the testing is, well, who benefits from 5 years of endocrine therapy and who has ultra low risk disease that really wouldn't necessarily require extended endocrine therapy and who should. So I think in the past, we would make a decision as clinicians that this patient is clinical high risk. And because they're high risk, they're likely to benefit from longer duration and benefit from extended endocrine therapy. But we now have genomic testing that's supporting some of our clinical assessment. Yeah, so it really depends. The patient's age, the patient's comorbidities, the grade, how hormone receptor positive is the tumor. So it's more complicated. You got to look at the whole picture. Yeah, it's not one size fits all.
Yeah, definitely. And I'm glad you brought up the genomic testing. We recently had a speaker series about genomic testing with the medical director from Agendia, Dr. William Audie. And he talked about mammoprint and the testing behind it and the information that can be derived from it. So I'm glad that you mentioned and that we have this technology to provide more accurate long-term and short-term care for our patients. It's amazing.
Yeah, absolutely. I mean, it's like I just think back to when I was training, which was a long time ago, but not too long ago, where, it's like, oh, you have positive lymph nodes. You definitely need chemotherapy. And you look back now, you're like, that was so unsophisticated. You just made a clinical assessment and just had this standard of care. And now it's like, oh, well, how estrogen receptor positive are you? What's the tumor grade? What's the oncotype? What's the mammoprint? What's their genetic test showing? I mean, it's amazing. It's this wealth of information that really allows you to tailor the treatment to the patient. I'm seeing all these patients where 20 years ago, I would be giving chemotherapy, and we're like, no, you don't need chemotherapy. Endocrine therapy only is what you need. So we were over treating and probably under treating patients now. And I think this is only going to get better. I think we're going to get more and more information that's going to really allow us to tailor treatment to patient, not expose patients to all the side effects that's not necessary. Yeah, it's a really exciting time to be an oncologist. And it's just it's really just really nice to be able to tell patients, you don't necessarily need to get the same thing your mom got 30 years ago when she got breast cancer. We have more
Yeah.
information now, and there are things now you can do to see if other family members are at risk. And now there are other interventions that may prevent that risk. We're screening better. MRIs, the 3D mammograms we have, the computer aided detection. Now AI is being included in screening mammograms. Yes, it's great. And I'm
It's
Yeah.
hoping
great.
this is no one dies from breast cancer years
Yes.
from now. That's the goal.
No, I
Amazing.
always say how complicated everything has gotten, but boy, it's a good complicated because
Yes.
I was that girl. Dr.
Yeah.
Taiwo, I was that girl. Estrogen positive, no lymph node involvement. You're going to do adriamycin, cytoxan, stage 3, biological, like that was it. That was my plan. There was no oncotype testing. There was no idea of any of the mammoprint, none of these other genetic type of or genomic tests. It just gives me so much hope, for our future. And I'm so glad that we bring all this to the community because I know it can be complicated, but this kind of complicated is so positive. It's targeted precision medicine that we're embarking on together and so valuable. I know we have another question here just about specific endocrine therapy being repeated if a person had progression of the disease and they have been on all of the available ones. So she had said that she learned from an NBC conference that long-term NBC survivors, 10 plus years, have been on specific endocrine therapy more than once. And a couple have been had 3 times on a specific endocrine therapy over years, but they were matched with different drugs each time. So she brought this to our doctor's attention. She said, you have been on them all and there's nothing more else we can try. And she won't repeat any. And she's still ER positive. Does any of this ring a bell, Dr. Taiwo, on her case and what we could offer some feedback?
Yes, obviously, without having the actual case and knowing exactly what's going on, it's a bit difficult to comment. Generally, when you think of the aromatase inhibitors, there are 3 that we use in the non-metastatic setting, which is letrozole, anastrozole, and exemestane. We also use it in the metastatic setting, and then we have fulvestrant, that is an injection that's used in the metastatic setting, and it's not necessarily an aromatase inhibitor. It really works to deregulate the estrogen receptor, so it really works slightly different, but they're all working to really prevent the activity of estrogen. Generally, when there is progression on one aromatase inhibitor, maybe you switch from one to the other, but they're doing the same thing. So unless you're going from one of the oral aromatase inhibitors to an injection, which is working slightly different, we don't mix and match. That being said, it really depends on how long ago that person got their endocrine therapy. If you've been metastatic for over 10 years, at some point, maybe you got tamoxifen, maybe the tumor is now different, because not only are we getting all this information and doing all this genomic testing, we're also rebiopsying and we're doing circulating tumor DNA, and we're trying to see if there are mutations in the cancer itself, not inherited mutations. We call them somatic mutations. So the tumor may still be estrogen receptor positive, but it may be a different kind of estrogen receptor positive, meaning that it's no longer sensitive. It's developed a mutation that tells you it's no longer sensitive to an aromatase inhibitor. We do have, the ESR1 mutation. So there are all these things that we're looking at that tells you, yeah, even if they haven't seen this AI in the past, if you give it to them now, it's unlikely to be effective because the patient's tumor has developed a way to keep growing regardless of what you do with the estrogen, right? Then you have to find another pathway to block to prevent progression of the cancer. So yeah, sometimes you would use a drug that's been used before because it's been many years from when they got that drug, or you do a biopsy of a metastatic deposit. And even though it's an AR positive breast cancer, it's a different clone. So you may want to try what you've used before, maybe because this is a different kind of cancer. But if you've developed a new mutation, then it's like, letrozole may not work, anastrozole may not work, exemestane may not work. Let's do something else. So it's always a conversation to be had. And I think this questioner is bringing up a good point, and I think it's just a conversation with your oncologist. Can you explain to me why you think this particular drug is no longer effective or not a good idea? Do I now have a new mutation that tells you this is no longer going to work? Or are you now HER2 low? And they're like, let's stop wasting time. We know this drug for HER2 low is probably going to be more effective than everything else. This is why I really want to try this. So I think it's a conversation. I think patients just want to feel not just seen, they want to feel heard and they want to be part of the decision making. And so when you're saying, I don't think this is a great idea, tell them why.
Yeah.
And I'm sure, yeah, so that's what I suggest. Just,
Thank you for that. Yeah, it's their life, Dr. Taiwo. They need to question.
yeah.
They should not feel badly about questioning.
Yeah, no, never, never. I
For
tell
sure.
patients if you feel uncomfortable asking your doctor questions or you feel like they get annoyed when you ask them questions. I mean, we're all busy, we're all in a hurry, but it's like
Yeah,
then you get a new doctor.
yeah,
If
cannot agree more.
yeah, if they're mad at
Yeah.
you, get a new doctor.
Yeah, thank you for that. I
Absolutely.
think we're going to wrap up with one more question, right? I mean, Dr. Taiwo, I could listen to you all day. I have learned so much on this segment because so much has changed from what I have in my head about tamoxifen and the
Mhm.
decisions I had to make. And I did the best I did with the information I had at the time. And it's
Mhm.
just so good to hear all of the progress in the studies, and especially for our young women that we see more and more of, and them being able to live their life, and have children if that's possible again. And it just, I was so happy to hear all of the progress that has been made and studies that are out there. One thing we hear quite a bit about in our community is dose reducing. And is that a possibility in taking tamoxifen? I know that the recommended dose is 20 milligrams. Could you actually dose reduce if you're having a lot of tough side effects?
It's a great question. There's a study that's actually looking at that, which we're opening here. So we do have data in DCIS, right? There's we call it baby TAM. So studies were done looking at the standard dose of 20 milligrams versus low dose tamoxifen of 5 milligrams, which is 10 milligrams every other day, because the lowest dose of tamoxifen is 10 milligrams. A 5 milligram doesn't exist. So we have you take 10 milligrams every other day, but that's in DCIS. And the study showed no difference. So
Wow.
for our patients, I mean, we still start the standard dose of 20 milligrams in DCIS because that's standard of care, but we are very quick to reduce to that baby TAM dose of 5 milligrams daily or 10 milligrams every other day for toxicity or side effect. Whether you can do that in the invasive cancer space, so stage 1 and higher, we don't have that data and we generally don't do that. But there is a study, it's called the low
Great.
TAM study, low tamoxifen, where it's looking at in the postmenopausal patients, looking at, standard AI actually versus low dose tamoxifen to see if it's just as active. So, maybe a different response couple years from now. But generally for invasive breast cancer, the standard dose is still the 20 milligrams of the tamoxifen.
Yeah, good to know that it's another conversation you can have, right? Like
Mhm.
you can have these conversations and there's studies happening as we speak.
Yeah.
One area, I know I said it was the last question, but this one's burning too. One area that we hear a lot from our community is the amount of anxiety, depression, mental health issues that are connected with tamoxifen and some of these
Mhm.
drugs. And
Mhm.
they're dismissed, Dr. Taiwo. They're dismissed by their physicians, just saying it's just hormonal. Don't, it will get
It
better.
is hormonal, it is hormonal, but it's real.
But it's real.
Oh
And
gosh, it's so
it's
real.
so real that it takes their breath away. They feel like they have this weight on their chest that they can't live their life, Dr. Taiwo. And I guess that's why when I hear about possibilities of dose reduction, could that be the answer to let them live their life and have favorable outcomes? Because yes, it's hormonal, but oh my gosh, it's real. It's not,
I just
those
find it
thoughts.
interesting that hormonal is like, it's just hormonal. For me, it's like it is hormonal, but it is a medical problem. We actually know it's hormonal because we are doing this to you. The drug is doing this to you. So it's actually more important because you know what the issue is. You don't just dismiss it because you actually know what
They're
the issue is.
they're feeling dismissed. They're feeling like they have no choice and nobody's listening to them and that they should be able to manage this on their own.
Yeah.
And hormonal is just like, back in the day when they talked about menopause or back in, right, like, oh, it's just hormonal. It's 1/3 of our life, for goodness sake,
Yeah,
right? Like
yeah,
we
yeah.
gotta talk about it more. And I just see people feeling dismissed and not heard. And it's tough. It is tough, some of these side effects. And for them to be validated about it, I think could actually help move forward with solving their problem, right? And to get the attention that they need, whether it is counseling or some acupuncture or an additional therapy to help support that mental well-being.
Yep.
I didn't know how often you got to hear about the mental stress that comes from some of these hormone treatment drugs, but I thought maybe I'd touch on that a little bit.
Yeah, no, it's a great question as well. And I mean, we see it, enough times. I would probably say about 10 to 15 to 20% of my patients do struggle with just low mood. I don't see a lot of the extremes, but that does happen where I've actually had to stop the medication. It's like, yeah, we're treating your breast cancer, we're treating you to reduce your risk of recurrence. You actually don't have breast cancer right now. We're trying to reduce the recurrence, but the quality of life at that point was just zero. And so the decision was made to hold the treatment. The patient had tried everything, acupuncture. She was seeing one of our psycho-oncologists here, going
Yes.
to the gym every day. I mean, doing everything that she needed to do. And it was, let's give you some time off of the medicine. Maybe your body just needs to rebalance itself and we can re-challenge you. And sometimes just hearing that is enough for a patient to be like,
Oh,
okay, I get a little bit of a break. And then for those who are just sort of having this low level, whether it's dysthymia, that anxiety and depression is there. Like you said, I think being validated, sometimes that's all they need to know. Like,
yeah,
this is hormonal. It's the medicine that's doing this to me. It's just not something in my head. And so
right.
somehow they're able to, through therapy, get tools to get them through those periods where they're really down. But we definitely take that very seriously. I have a young woman right now who has a history of depression prior to her diagnosis of breast cancer. Thankfully, it's very low stage. It actually was a stage 0 DCIS, and she's in an acute depressive stage right now. So we're just going to hold her tamoxifen.
Yeah,
Continue seeing your psychiatrist. Let's get your medications optimized, and then we'll have a conversation when we think mentally and emotionally you're stable. It's all part of the assessment.
perfect. Thank you,
I wish
Oh,
I wish every physician was like you, Dr.
I
Taiwo.
know.
I
Me
really
too.
just so
Yeah.
the
Great talk.
collaboration. Yeah,
Hmm.
absolutely. It's just really wonderful to hear, the type of conversations you have with your patients and sort of setting that example and how validating it is. So I think you put it perfectly. That's just wonderful to hear.
Yeah. And I love the comment about, yes, it is hormonal, and yes, it's an issue. Because
Yeah.
I think those things about, oh, it's hormonal, was being connected with being dismissed, and you should be able to figure it out. Like,
Mhm.
it
Yeah.
wasn't like, it's not a big deal, it's just hormonal, right?
Exactly.
And
Yeah,
it's like, it
big
is a
deal.
big deal.
Yeah, it's a big deal.
Big deal.
Yeah.
Oh, you're the best. Thank you, Dr. Taiwo. Thank you for taking the time. We definitely went long, but this is, I know we have so much information that our community is just going to hold on to and be tooled now to go to their physicians about. So we appreciate you. Thank you for all of your time today.
Thank you for having me, and thank you for the amazing work you guys do. It's fantastic. Keep it up. We need
We
you.
are. We are. Thank you.
All
Thank
right. Take
you.
All
care.
right. Have a good afternoon. Have a great weekend.
Bye.
Erin, that was so good.
Oh
Thank you.
my gosh, so
Yeah.
good.
Yeah.
So informative.
Yeah. And it just helped me too. I'm revisiting 20 years ago, and I did not have all this information about tamoxifen or the
Yeah.
studies or the facts or the fact that, you wanted to have more children and what are your options? And it just
Yeah.
was not that.
Yeah.
So happy to hear this for our younger patients that they can have
I know.
really
I know.
important conversations. And we're going to be sending this link out to so many people to listen to.
Absolutely. And even just setting the stage so that our patients can understand what's happening with
Yeah.
each medication versus just starting it. So, I mean, what a clear picture that we have. And hopefully, all of this just kind of, brings clarity and facts to, our community and the decisions they make about their
Yeah.
diagnosis and their long term health.
Yeah. And conversations to be had. right? These
Absolutely.
conversations are to be had, and you are good to lead them, and we will help you, right?
Yeah.
So, all right, Erin, always good to be here and, join you in these Ask the Experts. I learned so much each and every time. And how about if we finish off by thanking our sponsors and supporters once again?
Absolutely. Big thanks to our sponsors for allowing us to continue to bring segments like today to our Unite for Her community. So today's Ask the Expert is presented by West, Merck, Lilly, and Gilead Sciences. We have additional support from our gold sponsors, Pfizer, GSK, and Daiichi Sankyo, plus additional support from AbbVie, Agendia, and Tercera Therapeutics. So we are so grateful for their ongoing support and encouragement to have truly incredible experts like Dr. Taiwo today.
Yeah. I love that she talked about Mammoprint too. We just had that on.
Let's make sure that we link that out as well
Yeah.
in her library. So go to uniteforher.org/UFH Connect. It was our most recent speaker series, and you will continue to get more information and facts and understanding about that type of genomic testing. It was also a fabulous segment.
Yeah, terrific.
Great.
All right, Erin, another good segment. Thank you so much.
So good. Thank you. And everybody enjoy your afternoon. I will see you for our speaker series in May.
Perfect. Have a good evening, everyone.